Good afternoon. Thanks so much for coming. I appreciate your time, and we're going to talk a little bit about something I'm passionate about that's also the #1 killer in the US. So it's sort of a problem when I'm at parties because I love to talk about it and most people get a little afraid. So we're not at a party and we're going to talk about the good and the bad of all of this. So this is an interesting little video showing just a blood vessel. This could really be any artery of the body. And showing how the soft plaque will build up and then cause narrowing in the vessel. And so this is where, heart attacks can happen or strokes. And so we'll go into more details about that. So we're going to talk about diagnosing heart attack before a heart attack or sudden death. We don't want to do that after the fact. So a little bit about me. My name's Kim Brockenbrough. I am a physician and radiologist. I am not a cardiologist, but I'm a cardiovascular radiologist. So I've been imaging blood vessels since I was a resident in 2000. I kind of hung out with the vascular surgeons, made pretty pictures, and they kind of went, "Ooh, those are cool. Can you make more?" And so we just kind of would meet with them. And so it started out imaging the aorta, and then we imaged the renal arteries, and then so lots of arteries. The coronary arteries are a little bit trickier to image because they move. Your heart beats, and so you don't want that to stop because that's incompatible with life. So they're a little bit trickier to image than something like the aorta that moves a little bit, but not as much as your pump, the heart. So I'm from Chicago. You'll hear that in my accent probably. You'll know that, I don't know, I like pizza, deep dish, the real stuff. I don't eat that every day. You can't eat that every day and have a nice heart, but you can eat it sometimes. I was with I was with Carl for 10 years. Started some programs there, coronary CTA, doing imaging of the heart with a CT scan, 24 hours a day, 7 days a week for ER patients. Started up a cardiac MRI program, and then moved to the Pacific Northwest. And so I was with Radia and on staff. Mostly I was covering Swedish Cherry Hill, which is our big area cardiovascular center. Also on staff at Overlake, Evergreen, and Prov Everett, helping start up programs and doing cardiovascular imaging. And then I worked for an Israeli startup called Zebra Medical Vision, which uses artificial intelligence to diagnose different things like heart disease. They have since been bought by Nanox, but that was a really fun time and kind of gave me the bug to start my own company. So now I am the founder of CardioVision, which is down the street from Overlake, and we screen for heart disease. So heart disease, leading cause of death in men and women in the United States. 1 in 3 women and men die of heart disease. 1 in 8 women die of breast cancer. So it's really, really significant. 1,000 people suffer a cardiac arrest each day, and only 10% survive. Half of men who suffer from sudden death from coronary artery disease have no previous symptoms. And coronary artery disease is the leading cause of sudden death in the US. And it's treatable. And so that's the good news. That's like, if you hold on to all this, there's good news in this. But we're going to start with an anatomy lesson because I'm a radiologist and that's what we do. So your heart is your pump. And it's specifically the left ventricle. This picture is a little bit more of an artist's rendition than totally accurate. The left ventricle is a lot thicker than the right ventricle. So the heart has 4 chambers, 2 atria, 2 ventricles. The left ventricle pumps the blood to the rest of your body. The right ventricle pumps the blood to your lungs. So that muscle needs to be really not very strong. Your left ventricle needs to be really strong. So let's see if I can. So it's a pump. So it's the most important pump, and it's just a pump. I mean, and then your vessels are your pipes, and junk in your pipes is atherosclerosis. It's sort of that simple. The other thing that's important is the electrical system, and that's why I like this picture. Those little green lines there are the Purkinje fibers, and it's essentially the electrical system. And so if one of these goes out, and there's different nodes, those can go out and cause arrhythmias. So I'm sure you know people with atrial fibrillation. That's when they've got issues with the electrical system. And my theory is, and others as well, that the plumbing issues, if you've got issues with your plumbing, you can have issues then can cause issues with your electrical system. Any questions so far? And I've got a mic, and I'd love to make this as interactive as possible.
What I was wondering where the chambers are that you mentioned.
Oh, great. Yeah, good question. So here is the left ventricle, and here is the aortic valve. So that's going, and then here's the right ventricle, the right atrium, and that left atrium's kind of back there. And so arrhythmias on the right side are less of an issue than arrhythmias on the left side. Your right atrium, AFib, you can get your heart rate up to almost, it can go up to 200. Normal heart rate's 60, 70, 80. It can be good doing this, the right atrium. Nobody likes it. It's not good. It can cause clots, but it's not going to cause you to collapse and die. If your left ventricle does that, your whole pump, the pump to your whole body, then you collapse. So that's VTAC, ventricular tachycardia, ventricular fibrillation. That's super bad. So some arrhythmias are a hassle and not great, and some arrhythmias are death. So, any other questions?
When you say left or right, that's from the patient's point of view?
I don't know. It's probably the original. That's a great question. It's probably the original anatomist's point of view. It is on the left side, so it angles onto the patient's left side. Mm-hmm.
Patient's left side.
Mm-hmm.
So with that picture, it would be on the right?
It's right here, because I know that because it pumps out through the aorta. The right ventricle pumps to the lungs, and those are the pulmonary arteries.
Right.
Yes. And can I?
Well, with you presenting at Bellevue Club and everybody here has a passion for fitness and health, if you could talk about any impact on Zone 2 versus Zone 3 training in that pump. I mean, are we in a good spot with both those, or you talk about 50% not knowing they have it?
Yeah.
If you could talk a little bit about that, that'd be great.
So I'm a radiologist. I'm not an an exercise physiologist. I'm not a cardiologist. And so I don't know the answer to that question. My job is to make beautiful pictures and then interpret those pictures. And I know a little bit about some of the meds, but exercise, I know exercise is good, and that I'll leave it at that. Go ahead. Oh, she's got it.
You mentioned that problem with the electrical system is most likely to be caused by some plumbing problems. Could you elaborate what are the most typical plumbing problems that cause arrhythmias? I'm going to show you more pictures with the plumbing. Great question. All right, so here is the pipe, and here's the junk in the pipe. So here's a normal artery, and the arteries are the ones that
pump blood away from the heart, and the veins bring it toward the heart. So normal artery, fatty plaque, fibrous plaque, and this is showing two different things. Calcified plaque, and if it ruptures, it's a heart attack. If this happens in the brain, it's a stroke. And so our goal here is, to prevent this. So essentially, this is the pipe, and junk in the pipe's atherosclerosis, and statins can almost be like Drano. Now, I'm not saying take Drano. I'm saying statins can act similar to Drano with this kind of problem, in this kind of junk in the arteries. Any questions about that?
If someone was told,
Can you pass the mic back to her?
It's not me, but if someone is told to take a statin, do they need to do it forever, or is it temporary?
That's a great question. That's a great question, and I get asked that all the time. We've got another question over here. But so predicting what's going to happen forever is super tricky, especially in healthcare. The statins came around when I was in med school, and now the data on them is just like, they're super effective. They do cause some people muscle pain. That's real. There are new medications out called the PCSK9 inhibitors. And that's like Repatha, which is a shot every 2 weeks. There's another one out that's a shot every 6 months. So to say somebody needs a statin for life, they might just progress to a PCSK9 inhibitor, and then that might be a shot every 6 months or once a year. We may learn more about why this happens, and so it gets treated at more of the genetic level than at this level, at the Drano level. So I don't know. At this point, if somebody's on statins, and then sometimes people can have a marked change in their lifestyle. They say, I just lost 50 or 100 pounds, and then they might be able to go off of it. That's something that's good for the patient and their primary care doctor or cardiologist to discuss. But those are the reasons that it may or may not need to be on it for life.
So we're inside the artery.
Yes.
How long does the progression take from the left to the right? Or in general, how long would that take in someone's body?
That's a great question, and we just don't have any idea. I like to look at genetics pretty closely, and not that I look at people's genes, but just what's your family history. We see people that parents had heart attacks, people have heart attacks in their 50s. Likely that's going to be a genetic problem, trait, issue, and it happens quicker. Age is a factor. This happens to most people at some point in their lives. Some people it doesn't, and then we go around high-fiving. We'll be like, oh my gosh, we had a 80-year-old with no plaque. That's when we kind of look. That's kind of an interesting thing. It's pretty uncommon to see that. How fast this progresses, we don't know. How fast, and what statins do is melt this and then calcify it. So if anybody's had a calcium score, and we'll go through some of those, and there may be a quiz about the difference, what a calcium score looks like, so get ready. What the calcium does is, or the statin does, is actually melt it and then calcify it. So you want your calcium score to go up if you're on a statin, which seems like, well, we want it to be 0, right? Yes, everybody wants to be perfect. But if you happen not to be perfect, the calcified plaque is more stable than the non-calcified plaque. And that's something new we've just learned, that this soft is more likely to rupture than the calcified. But we don't know the time of it. We don't have that kind of data. A lot of the data around coronary CTA that we can see this really nicely is at this stage. And that's when I was on staff at Swedish. That's when we were looking at it. People were coming in with chest pain. Now, as a longevity practice, our focus is this stage and treating it way earlier than this.
Is the diet a factor?
Oh, sure. But I don't know what to tell you to eat. I think sugar is bad. And sugar on the blood vessels is super irritating. Now, does that mean you can't eat sugar? You know, some people process sugar well, and some people don't. Diabetics don't process sugar well. Pre-diabetes is essentially diabetes. You know, it's sugar on the blood vessel, and the blood vessels don't like it. I said I was from the Midwest, and I'm a good pie baker. My daughter's here. She can attest to my pies are really pretty good. I like sugar. I don't eat it all the time. I go exercise if I've had sugar. You know, sugar can, you know, some people do a vegan diet. Sometimes their vessels look great with that. Their cholesterol can be high, but their vessels look great. It depends. But I do know sugar's hard on the blood vessel. So here, any other questions?
Now, what about sodium?
You know, sodium used to be, it's harder, it can be problematic for people with high blood pressure. I think it's less of an issue. And again, I'm a radiologist. I know I say like, oh, you could do this, and then I go, well, I'm just a radiologist. I don't really know. But I haven't heard a lot of bad things about sodium lately, but that doesn't mean I actually know.
Does a CT score come on a regular lipid panel?
No, great question. So here, and the question was, does a CT score come on a regular lipid panel? So the lipid panel is just taking blood and looking at the lipids in your blood system, in your blood. A calcium score is actually a CT scan. And let's see if I can, my pointer here. It's this first picture right here. And this is a calcium score done on a CT scanner without contrast. So it's a really pretty easy study. And it will show calcium. And as we showed before, the calcium is sort of the end stage of atherosclerosis. The soft plaque, first it becomes soft, then it calcifies, you hope. And this just shows the calcium. So that's a nice test. It definitely, there's reams of data on it. The interesting thing is now, though, if somebody's on a statin, their calcium score goes up. And that's the goal, is for it to go up and then the soft plaque to go down. And that's what the statins will do. And so you want your calcium score to go up. And the initial, but if you've got a calcium score that's positive, you know you have atherosclerosis. And I'll show some more slides. Oh, and let me just.
There's a question here.
Yes.
What role does cholesterol play in the formation of plaque?
Great question. Great question. And the question was, what role does cholesterol play in atherosclerosis? Yeah. It's a factor. And it's a really important factor. And that's probably the best blood test you can get to determine if you have disease of your coronary arteries. It's not the only thing. We used to think it was just cholesterol, and that's why statins were really good, because it would lower the cholesterol. But it's also inflammation. And statins decrease inflammation as well. So they're doing two different things, and a lot of the data now that we see is like tooth health, dental health. There's a lot of inflammation in your mouth, and if you treat that, your heart disease gets better. You know, so it's two factors that we know of now. Could there be another one in 10 years that we don't have any idea? I'm sure, you know. But yes, cholesterol is a really important marker of atherosclerosis. And then so this is the coronary CT angiogram. And we use contrast with that, and you can see this soft plaque here. And that's the way to see soft plaque, is with giving contrast and doing a coronary CTA. And this shows it. So here's a narrowing of that blood vessel, and then this is a cardiac cath, also showing the narrowing.
Quick question.
Sure.
Does this mean that the only way to know what the condition is to go get the CT scan? I mean, is it one of these where it's another wonderful rite of passage of life that at a certain age you should be getting a CT scan?
In my opinion, yes. And we, but it's debatable. I mean, everybody gets a blood level done. Or not everybody, but that's sort of a standard of care to get the blood level done. Our recommendation, the healthcare system, I mean, I was in it I'm still in it. The healthcare system, and maybe you're in insurance, are you in it? Yeah, I mean, everybody's struggling in the healthcare system, right? I mean, it's just overwhelmed with the last 5 years and the last 5 minutes of people's lives. And so our goal, what I see the goal should be, is longevity. And that doesn't mean you're just alive, it means you're thriving. And playing pickleball, or maybe tennis. We can have that debate in a little bit. But, and so our recommendations is for men at 50 and women at 60 to get coronary CT angiograms, 10 years younger with risk factors. And before that, potentially a calcium score. If people are young and nervous or something, you get some information. Any other?
So the calcium score is just like on your blood test, or how is it?
The calcium score is, let's see, it's this scan right here.
Okay.
It's a CT scan, and most places that do coronary CT angiograms will do this as the first step, because it's just nice to know, like how much calcium do you have? But that is a CT scan as well. Yes.
So let's say you had a calcium score
Mhm.
and it was 0. That
Mhm.
means that there's no additional test needed to see the next pictures, how, with the contrast.
So the question was, if you have a 0 calcium score, are you good? Is that correct?
Yeah.
Yeah. And are you done? Potentially. And it depends on risk factors for people. Young people who are, maybe have chest pain issues, but it may more likely be anxiety. I'll just do a stress test or a calcium score. If it's negative, that's pretty good. But many people can have a positive stress test, positive or negative calcium score and a positive coronary CTA, some of that soft plaque. And I've got some cases that show that. There was a study out of Sweden within the past 3 years that had 20,000 patients, did both a coronary CTA and the calcium score, and about 14% had, with a 0 calcium score, had atherosclerosis, so positive soft plaque, but no calcified plaque. The risk factors for that are diabetes and elevated lipoprotein a, which is one of those blood markers. Those are the scary ones that they may have a negative calcium score. In my practice, I see it more than 15%, but it's just a little bit, and so it's you're gonna treat it now or in 5 years. It's probably not clinically significant. And then sometimes we see big mounds of soft plaque and a 0 calcium score. So it just depends. All right, so it's the pop pimple picture. But this is sort of what it is. And heart attacks are interesting. We could call this a stroke too. If it's in the vessels to the brain or the neck, it would be, that would be a stroke. And so, but this is a good visual. And the substance of a soft plaque is pretty similar to the stuff of a pimple. And there's different ways pimples, we've got one more pimple slide, even though the heart's prettier. So how do you know when a pimple's gonna pop? Well, you look at it and go, well, it's yellow, it's time. And you know, when you pop pimples, as we'll get into, sometimes a little comes out and sometimes a lot comes out. And so half of people, I think it's half, and I have to check this number, but many people who have a heart attack get an EKG while they're having the heart attack, and it shows a previous heart attack. And it's like, how did that happen? My theory is it was a little pimple that popped and not a really big one. And so it's important to know if you've got that pimple in your arteries and to be able to treat it. All right, anybody know who this is? Okay.
Peter Attia.
Yeah, and what's his shtick?
Oh, longevity.
Longevity.
Medicine 3.0.
Yes. So Peter Attia, and yes, there he is with Oprah and his new book, Outlive. So Outlive's a great book. He's kind of an interesting guy. He can actually talk about statistics and make it interesting to me. So I think so he has a podcast. He also, he has opinions on everything. And so his opinion is that the coronary CTA is a better study than the calcium score. Just because of what you can see, because of that non-calcified soft plaque. And there's a CT scanner. I don't know if that's not ours, but we have one just similar. So one of the things also that the healthcare system uses routinely is a stress test. And stress test can be in the form of, you can get a nuclear stress test, which is what this is. You can get an echo stress test. I think you can get one just looking at an EKG. And basically, it's looking at the heart at rest and then stressing it and seeing if there's a flow restriction with exercise. And if there's a flow restriction, then you have coronary artery disease. So this is very common. Okay, so I have a question. What % narrowing of a vessel will you have if your stress test is positive? And I'll give you some more pictures. Let's go back. Let's go to this picture. Okay, so this is narrowing, a little bit of narrowing, maybe 30% of that vessel. So that's a 30% stenosis. Okay, so what % stenosis do you need to have a positive stress test? 20%?
85.
Okay. Faye says 85. Anyone else?
10.
10, okay. 50. I used to say that. I used to tell people that. Yeah, right, yes. You can hedge your bets with 50. You're close. I used to say that, and then I just met with some cardiologists. We had going over stuff, and they said, no, it's 70% stenosis. 70% narrowing. And if it looks at relative loss of blood flow. So if all three of your main vessels, your right coronary, left anterior descending, and left circumflex arteries, all symmetrically don't supply blood to the heart, you might have a negative stress test. So it's a very imperfect test, and it's 70% narrowing. So if you've ever had a negative stress test or have a family member and they're like, oh, you're good, it just means you don't need a stent. It doesn't mean you don't have atherosclerosis. And again, the medications will melt this. And that's the beauty of that. That's why I still talk about this at parties, because there's a good end to the story. It's not, you're just gonna die, don't get any more toothpaste. There's something that'll help. And there's lots of things that'll help. And so, all right, let's go back. We're gonna show some case. Oh, I'm going the wrong way. Let's see. Okay, pop pimple. Any pimple questions? And then we went to Peter Attia, we got that, we got the stress test. So it's good. And I often, the trick, I'll recommend this sometimes, because if I see a lesion that's really kind of, there's calcified, there's non-calcified, it's hard to see, I'll recommend a stress test just to like confirm the patient doesn't need a stent. Like I love stress test, but don't think you're all good if your stress test is negative. Okay, and then it's the nice glacier picture. The iceberg, calcium score may not be enough. All right, so we're gonna go through some cases, because that's what radiologists do, is show cases and pictures. So this is the heart, and we're looking at it from the top. So these are axial images. And here is the heart, lungs, spine, little bit of spine there, and ribs. And here's the ascending aorta. And the vessels that supply the heart are the coronary arteries. And I kind of went through those. There's 3 of them. This is the left main, that right here is the left main coronary artery. And then, this patient has been on statins. And this is still the left main. And this is what statins do, which is beautiful. They take a plaque and they calcify it. And that calcium isn't like a big chunk of calcium in the vessel restricting flow. It is on the periphery of the vessel. It's almost like a stent, just like makes its own stent. It's lovely. The soft plaque there, right next to it, is scary. That is what can pop like a pimple. That calcified plaque doesn't pop like a pimple. This is what can pop like a pimple. And so this patient was on statins, doing some work, helping some, but not all of it. And so we recommended this patient go up on statins. It's kind of that easy. If they can't tolerate statins, then there's the PCSK9s. So there's ways to help. All right, now we're doing a coronal section. So it's all those axial sections stacked up. They're less than 1 millimeter slices, and then we go through it coronally. So here's left ventricle, here's the aorta, here's the right coronary artery, and it's super hard to see, but this is the pericardial fat, and see how that narrows there? You can see the narrowing. It's hard to see the soft plaque. See that narrowing right there? So guess what? This is a younger female patient. Guess what her calcium score was? 0. She had elevated lipoprotein a, and that's a really big marker for scary stuff. And she's got a big soft plaque here. So when I hear elevated lipoprotein a, I don't want those people to just get a calcium score. I want the full coronary CTA because she needs to be on treatment for this. We don't want that breaking off, even little bits of it breaking off. Any questions?
So we talked about clots,
Mm-hmm.
and are there two, like your stroke could be caused by blood clotting?
Great question.
And/or plaque breaking up?
That's a great question. So is it a clot or is it the plaque breaking off? Like, which one is this? It's both. What happens is this plaque breaks off, it pops like a pimple, even a little pimple or a big pimple breaks off, and then the platelets, it causes a coagulation cascade. And it just starts, because it wants to heal. The body wants to heal it. And so the platelets jump on, and then more blood products jump on, and it clots off. So it's a combination of both. Mm-hmm.
What were her symptoms since she was so young?
She didn't have symptoms.
So why would she?
So we screen for heart disease. Our patients don't have symptoms, generally. Sometimes people come in with symptoms, but generally they don't have symptoms. It's just, and she was lucky, and she had an elevated lipoprotein a. And her doctor said, okay, let's get further imaging. Yeah. I think there was a question in the back. No? Yes?
So would the treatment be the statins then, or what would the treatment?
You know, lipoprotein little a is a little tricky, and I'm going to pull my radiologist, I don't really know card, because lipoprotein little a, I think they're coming out with a new medication to specifically target for those patients. But it's not as easily treated as maybe without the lipoprotein little a. But I think it is statins, and that's why I refer to cardiology all the time, because that's something that they're more attuned, you know, they know all the meds and which ones to use. Any other?
So basically, that person getting those results should then see a cardiologist?
Absolutely, yes. And that's what we do is everybody has a referring doc, whether primary care or a cardiologist. And we work with cardiology that, you know, that's what I do in my practice. What other practices do, I'm not sure. But we work very closely with cardiologists who are able to go to that next step if needed. Yes?
So looking at these images, should we consider this part of our preventative health care? You know, if we're proactive in our health care, we should be self-selecting and saying, I want this scan.
Yes.
And then that leads to a cardiologist if the scan generates concerns?
And often it's the, you know, if we see anything, we get concerned, right? But much of this is treated medically. And so, you know, yes, it's great prevention, it's great longevity. And so our focus, I was saying the healthcare system's just overwhelmed with the last 5 years and the last 5 minutes of people's lives. Our goal is for people to get to 100 and happy they're 100. You know, doing well, and this, treating this earlier rather than later is part of that process. All right, we got another one. Okay, what's this? Anyone want to know which big blood vessel supplies the coronary arteries? ACE, what? Atrial? No, but close. Atria is right, looks like right there, that's probably SVC. This is the ascending aorta, and this is the descending aorta. And here is the left anterior descending coronary artery. Here's the left atria. So this is where people get ablated when they have atrial fibrillation. We image this, and this is the pulmonary veins, the left atrium. There's a left atrial appendage there. And so that's what you ablate when you get with AFib. But this is what I'm looking at, is that coronary artery that supplies the pump, that is the energy for the pump of your body. And so this patient has a new onset supraventricular tachycardia. So supraventricular means above the ventricles, and so it's the atria. Like, it's not the end of the world. It's not a ventricular tachycardia where somebody could die. It's an annoying supraventricular tachycardia. And my daughter has it, and so, or had it, I think and so I know how to deal with that. You know, put face in ice water, do a bunch of vagal maneuvers. And so so he has a new onset in his 70s, and he's been on statins for 15 years. And so it's like, what's going on? Is there a plumbing problem? Because we know there's a new electrical issue. Is there a plumbing problem? So we see there's calcified plaque, which is good. That kind of acts like a stent. That's good. We knew he had atherosclerosis. But all those little bumps are soft plaque. And that is treatable. And that can flick off. And we saw, and my theory, and I don't know if is that little tiny pieces of this, let's go, little pieces of this can flick off and damage little nerves. And so a new onset arrhythmia can maybe mean it's a plumbing problem. And little pieces flicking off, you don't think of it like the big heart attack, but it's still a problem. He had to get ablated. He had to, get that treated. And he also went up, we doubled his statin dose because he's not being effectively treated. So you double the statin dose and we'll follow up in a couple years just to see how that's looking. Any questions? All right, we got another anatomy. Oh, okay, let's go back. See how we are on. All right. Okay, so here's a patient, 50-something, 52, I think, year old gentleman whose father had a heart attack in his 50s. And he's like, well, I run, he smoked, I'm good, right? I'm like, well, maybe. So his calcium score was 968, which is really, 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 really high, especially for a 58-year-old, 54, I think it was 54. And so he's in the 90th percentile. That means only 10% of people have a higher score than he does. So and what's interesting about that, the reason I show this is it used to be said that someone with a really high calcium score, you don't do a coronary CTA on because you can't see it well. You can't get a good image. But this is sort of this left anterior descending. So here's ascending aorta, descending aorta, left atria, and here we can see, even with that really high calcium score, we get a beautiful picture of his left main and left anterior descending. And there's a little bit, he's got calcium sort of all over. It's not just one big clump in the left anterior descending. Now, does anyone know the other name for the proximal left anterior descending coronary artery? Yes, the widowmaker. So that's another one that isn't a good party thing to talk about. Oh, you must have a widowmaker, let me have another drink. So, but this is where atherosclerosis starts. I've been looking at tons of coronary CTAs in the early stages, not in the stage when people are having chest pain and potentially heart attacks, but in the stage where it's preventative, it's for longevity. And 99% of the time, it starts in this proximal left anterior descending coronary artery, which is the widowmaker. So I try to refrain from telling everyone, oh yeah, you've got disease, it's just in your widowmaker, But the focus is, and here's a little bit of that soft plaque. Those little bumps are the soft plaque. And so sometimes it's not as easy to see as just a big hunk of soft plaque. It's just can be little bits of it. But that's treatable. It's treatable, and it can flick off and cause problems. It can cause distal emboli and can lead to problems of the heart. And if it's in the brain, I think it leads to dementia. And so, getting on the statins and sort of cleaning that out is helpful. Let's see, we're going the wrong way here. And so I've talked a lot about statins, and they're not without side effects. Definitely diet, exercise can help as well. Stents, bypass, and statins have all been shown to prolong life equally. And so now the focus is really to give statins. And so they're really effective. If they're not, you don't want to stop. If you have muscle pain or know somebody that gets muscle pain from the statins, don't stop the statin. Do what you need to do to get your insurance company to pay for the PCSK9 inhibitors. And generally, it's failed statin therapy. And sometimes you need to fail 2 medications or 3 medications. And because statins are essentially free, They're generic now. The PCSK9s are new medications. They're expensive. And the statins are really quite effective, but they do cause side effects. The PCSK9s, very few side effects. My cardiology colleagues just kind of go, oh, those are the best, because they don't have any issues with them. I also think, and this isn't true for all primary care docs, but I think if I was a primary care doc, often statins, because of the side effects, are prescribed in the lowest dose possible. And so, because people don't want their patients to stop taking them for if they get side effects. So let's give you a low dose, you're on something, and you'll keep taking it because you're not having side effects. But that could mean plenty of people have heart attacks on statins. And so it may not be the right dose. And so I think it's super important that if somebody's been on a statin dose for a long time, just to get a check to see the roadmap is, here's your coronary arteries, here is what they look like, and if you have soft plaque, I'd go up on your meds. Any questions about that?
Does the plaque tend to build up symmetrically, or can it be on one side? Because then the view angle of imaging would be important then.
Totally, yeah. It can kind of spread out, it can mound up, it just depends. It just depends. I see lots of different things. I think with diabetics, you see kind of more diffuse, and the arteries look really kind of hazy because there's so much inflammation. Some, like that lipoprotein little a woman, just a mound of soft plaque. It was pretty focal. So it depends. Yes?
I have a question about situations where you have some soft plaque.
Mm-hmm.
Is it possible for it not to show in your blood tests?
A blood test is a point in time. And a CT scan is a map. And so whether you ate, well 2 weeks before your blood test and kind of got a good score and you're like, yeah, I'm good. This is the map. Like you can't hide from it. If
It's possible, in other words, have perfect cholesterol and yet have soft plaque.
Cholesterol is just one marker.
I mean, all the other areas.
If everything's perfect, I don't know. I don't know the answer to that question. Mostly we get people that come to us that have one of those markers is off. And it's also a function of age. So the older you get, so I don't know the answer to that question. Mm-hmm. Yes?
So it sounds like what you're advocating is they put you on a statin because one of your markers is not optimal. And so you go on the statin for a period of time, but you really don't know how effective it is or whether you're on the right dose unless you do some kind of imaging to get the map to see, yes, indeed the plaque is calcified, but there's still some soft plaque. Maybe you need to have a higher dose of the statin.
Correct. And that's my thought process as a radiologist. And I image a lot of cancer. And so with cancer, somebody gets and people hate when I compare heart disease to cancer, but it kills more people, And so people get a cancer diagnosis day 1. Day 2, they get imaging. And then day 3, they get imaging, or they get treatment. And then in 3 to 6 months, they get more imaging. We don't do that for heart disease. We get somebody on a statin dose and go, oh, your blood levels are pretty good, I think you're good. I don't think that's the whole picture. Yes?
Do all of the angiograms require dye?
They do, yes. The calcium score does not. But to distinguish, so this is a patient in his 40s, had a negative calcium score 3 years ago and showed up with just a little bit of calcium. So this is his calcium score, and that's without the dye. What you can't see without the dye is that soft plaque right there adjacent to the calcified plaque. And if he didn't have any calcified plaque or soft plaque, I'd be like, maybe go on a little bit of statin because your body's sort of treating it. But with that soft plaque there, it's like, you need to go on a statin, you know? And so that's the benefit of the dye. It's this study versus this study. And again, a radiologist always wants more contrast. And so, and then the other thing, just because we can see things better. This is, you know, kind of gray and white. This is lots of shades of gray, and we can really tell anatomy better with that contrast. And then with a coronary CTA, most places we give medications to lower the heart rate so that, because it's like taking a picture of a child or your puppy, you know. You want them to be still when you're taking a nice picture. So he doesn't want me moving too much around because it's hard to get me. But that's the same with the heart. We want it to just, I want it as slow as possible. So the medications I prescribe often make people feel worse. We give a beta blocker to lower the heart rate. So we image it during diastole when it's like filling up. And we can get a nice picture there. We give nitroglycerin, which dilates up the blood vessels. That gives people a headache. I mean, beta blockers kind of make people feel tired. The nitroglycerin gives people a headache. We tell people not to take caffeine because that'll increase their heart rate. So people come in, and then we give them contrast, and it makes them feel weird and, you know, funny taste and a warm sensation. Everything I prescribe makes people feel worse, but I like pretty pictures, and so that's why I do it. And so, yeah, I mean, I think that, so that's the difference between those two, and that's the importance of the contrast.
Is contrast a high-risk procedure?
No. Contrast used to be the new contrast. That's why I say, you know, I can't predict what's going to happen in medicine, because it used to be the non-ionics or the ionics. When I was in residency, we had it at the VA still. We're giving ionic contrast to the vets, and every time they would get a scan, they'd throw up right after the scan. Like, oh my gosh, you know, just get the new stuff. So the new stuff people do fantastically well. The new contrast is people do really well. It used to be more of a problem than it is.
If you're allergic to the iodine?
If you're allergic to iodine, so it depends on the allergic reaction. Hives, I'm not afraid of. People's throats closing off, I am afraid of. So it depends. And, you know, there's pre-medication we can do with Benadryl, you know, steroids. And it just depends. This is a screening test, so anybody that's had any type, and for my practice specifically, we're an outpatient facility. I would not scan anyone that has had an anaphylactic reaction to contrast. It's just not safe. Hives, people get hives, you know, I'm not super worried about hives. So yeah, it depends. And really, the older contrast, more people had reactions to them than the newer stuff. Yes?
I have two questions.
Sure.
One, how long do people feel crummy after all of these awful medicines you make them take? So is this just a passing thing, or is it for a whole month?
Oh.
And secondly, you mentioned one of the important things is the reluctance of normal cardiology patients who get routine checkbacks to prescribe this kind of investigation. Is that because of cost, and how reluctant are insurance companies for, let's say, Medicare patients who get supplements to, what is the availability of this to a normal person who isn't in an extreme situation?
Great questions, great questions. So the first one is, how long do I make you feel awful if you come in to see? It's essentially, some people feel fine. With the beta blocker, I have patients have a driver bring them in. because I just don't know how people are going to react. Some people are fine and some people aren't. Mostly people are mad at me about the caffeine. It's not so much, they're like, I had one he was like, well, if I take it 10 hours before and I get my study at the end of the day, I'm like, no. I know when you've had coffee and I'm going to give you a hard time. So mostly that stuff wears out. The nitro is 5-10 minutes. These are really quick acting medications. So it's a short period of time, but enough that I like the patient not to drive home. And it depends on each patient. The second question is cost and insurance and availability. So insurance does not cover it doesn't cover a calcium score generally, or a coronary CTA, from what I've heard at all. Some of the supplements may, and I'm not sure about those. But my understanding is Medicare does not cover them as far as a calcium score. The coronary CTA is covered with chest pain. And so if people have a history of chest pain, they can get those, and that has increased usage because we've been doing coronary CTAs for I don't know, 15 years or so, and it's just now getting traction with regular guidelines saying you could either do the stress test or a coronary CTA, and so there is that availability. As far as longevity, there's no coverage. Yeah. Any other? Yes.
So what's to keep me from walking in and saying I've got chest pains?
I can. If people can tell any kind of stories they want to tell.
Well, I'm just saying, if the insurance is set up that way, I mean, how can you diagnose chest pains if the patient thinks?
That is true. That is one way to get one paid for is by insurance, is to say you have chest pain.
No charge for my tips today.
Yes.
This is incredibly fascinating, so thank you.
Thank you.
What frequency? So you go in, you get a coronary CTA, get contrast, you say, dude, perfect. How long should I wait before I think about
the next one? So perfect is kind of rare. A lot of people have a little something. So generally my recommendations are, if I see something that's approaching 50% narrowing, I'll say let's come back in a year, because I really want to make sure that that's going down and not up. And there's a lot of soft plaque. If somebody's near perfect, maybe 3 to 5 years. It depends on the age too. Somebody, really young people, a lot of times I'll turn them away. Like, you know what, you're fine. And then one time I did that too. I saw a patient, or one of my first patients. He came in, and it turns out he was diagnosed with reflux. And he gets just a calcium score, and he's in congestive heart failure. And so I was just like, calling my friends up, like, you need to get this guy in right away. He got in right away. He ended up getting stents. So then he, felt a ton better, did really well, and then told his church, hey, she knows about coronary artery disease. So I was getting 30-year-olds coming to me, and I'm like, I know he said that, but you're okay. And then one of these people came to me. I told him, no, we're not doing you and your 30-year-old, we're not scanning you and your 30-year-old wife. And then his dad passed away in his 50s of a heart attack. So I will image 30-year-olds, and I start with the calcium score, and I really talk to them. South Asian descent, I'll probably do a coronary CTA. People of Indian heritage, they have a lot of coronary artery disease. Family history is a big thing. If your mother had a heart attack in their 50s, I'm going to image you in your 30s. But most people, I'm having, so it's super dependent, but does that? Yeah. Any other questions about this?
What is causing the, you hear about these younger teenagers that are having heart attacks. What is the cause of that, and what are there markers? Are there anything? They just don't seem like they're old enough to have this.
Right. So most of heart disease is secondary to the plumbing, the coronary artery disease. But in the kids, it's often two things. It's hypertrophic cardiomyopathy, which is a thickening of the heart muscle that's genetic, and it can cause an arrhythmia when the heart's really beating fast. So I think that's the number one cause of heart-related death in younger people, and it can be athletes. These are the athletes that you're like, and that's better diagnosed with MRI is the better way to diagnose that. And it's super rare, so screening for it isn't super effective. But it's so tragic. You see this, healthy athlete drop, and those are terrible, and not this. And then there's also coronary artery anomalies. And so instead of the normal location of the artery origins, it can be between the pulmonary artery and the aorta, and it can compress off. And that's really rare too. I mean, I just had a patient with one, but it's very rare. So that's usually, so I don't recommend this for athletes. All right, but I do recommend it. Oh, okay, let's talk about this one. So what's interesting is, we talk about what would the healthcare system, what would docs in the healthcare system recommend? It's certainly not guidelines. It's not covered by insurance, and so it's hard to know. They're reluctant to recommend it. And I think where I see patients is with physicians that are more focused on functional health and just longevity. These are my referral sources. But I think a great question is, and we're in the process, I meet with lots of doctors every week, just reviewing the soft plaque, because prior to COVID, all I talked about when I would dictate a coronary CT angiogram was the percent stenosis. That's all I talked about. We didn't talk about soft plaque, maybe a little, but it wasn't the focus. Now it's the focus. It's really, this is what's preventable, this is what's more likely to rupture, is that soft plaque. And so this is an interesting question to pose to your primary care or a primary care provider. If I have soft plaque, would you increase my statin dose? And if the answer is yes, then you probably need a coronary CTA. If your blood levels are all perfect, maybe it's okay. But so that's just what we're doing. And again, our focus is 100 years, living to be 100 years and happy. Any questions about this? Yes?
Let me ask you, are there certain degrees of heart attacks that create less damage to the heart and others that create greater damage?
I think absolutely.
And you can see that in your radiology?
We see that, that's more of a clinical, we see that clinically, we can see that on imaging. So, and we see more, what we see here is within the vessel, and if it's likely. So that widowmaker position, so this position is the left main and then the left anterior descending. This is kind of the widowmaker position. If you get an occlusion here, that takes out the whole left ventricle. That's why they call it the widowmaker. That's a big heart attack. But there's lots of little vessels. So here's a ramus branch. Here's a tiny little septal perforator. Do you see that little vessel there? You can get emboli from this that go down south or go to the littler vessels, the smaller vessels. and can cause damage there too. And that's why I think a new onset arrhythmia might be a sign of a smaller vessel damage. Dementia, I think, is small vessel disease. And it's not a huge soft plaque in your carotid occluding it. Then you've lost one side of your body and everybody knows you've had a heart attack. But the little things like, or progressive smaller events, I think is small vessel disease. And I think it's little bits of this going down and occluding smaller vessels. So yes, absolutely, it can be bigger or smaller. And I think it's the small stuff we don't recognize. I don't think the small stuff causes heart attacks necessarily, or maybe it's indigestion and it goes away. You think it's indigestion and it goes away. So I think the smaller ones, stopping the smaller ones, I think is the way to get to 100 happy, and happy you're 100. Yeah. Yes?
What's the average cost for a CTA insurance?
So I don't know. The coronary CTA, our cost is $9.99. And it's pretty low, and I'm not sure how long. That's our pre-COVID pricing, and I'm not sure how long we're going to be able to keep it at that point. I know places that, I think the hospitals are more like $2,000 if you're going to pay out of pocket. I've heard some places charge $5,000. So it really depends on the location. And yeah, I'm not familiar with everybody's pricing. And calcium scores range in price from around 100 to 200. Any other? Yes?
Has there been an increase in heart disease after COVID? Because of COVID afterwards?
Yeah, that's another one I'm not touching. There's definitely pericarditis and myocarditis related to COVID. Yeah. And then there were delays in diagnosis because people didn't want to go to the hospital because they didn't want to get COVID or they had COVID. And so they were having a heart attack but didn't go into the ER. There's that too. As far as atherosclerosis, I'm not sure. Yes?
Are they still recommending low-dose aspirin to take daily?
I
heart attack?
think that that's a question I don't know the answer to. I think that's changing. Because it used to be, I think if you do the statin, you're preventing this from breaking off, and then you don't have that cascade of the clotting. The aspirin treats it at the stage where it's clotting, but if you prevent that, you're kind of a step forward with the statins. But I don't know the answer to that. I would say if you're in the middle of having chest pain, I would take an aspirin.
And what about the symptoms of a heart attack?
Everybody's are a little bit different, and I think men and women are different as well. And they're different. And I'm not really at that stage. My first part of my career, the first 20 plus years, was in a hospital reading films. And now I see patients, but they're healthy patients. They're before that heart attack. So I don't know all the symptoms. I mean, classically, it's left-sided pain, it's chest pain, it's like an elephant sitting on your chest. But I think a lot more happens prior to that we're just not aware of.
And I think they added jaw pain that women had that men didn't have.
Maybe.
As one of the symptoms.
Right. Yes.
And a vegetarian diet?
Yeah, I do know as far as diets vary a lot, and I don't have a ton of opinions on diets. I do know that sugar is hard on the blood vessel. And it's worse if you don't manage it well. If you manage sugar well, great. If you are diabetic, you just don't manage sugar as well, and it's harder.
So there are other imaging tools that you can use. So you mentioned like MRIs,
Mm-hmm.
things like ultrasounds that can actually get a view on this that are maybe more accessible.
The ultrasound does not. The ultrasound looks at the function of the heart, And it can also be used with a stress test. And so that's really good for function. An MRI is sort of an echo or ultrasound on steroids, like it's better. As far as looking at the coronary arteries, CT is the best for that. MRI doesn't really show the coronaries well, but CT doesn't show the muscle as well as MRI. And echo shows the function way better than a CT. So they're all sort of, they can be very complementary.
Yeah. So you almost need to know what you're looking for to know which test.
Exactly, absolutely. And a cardiac cath will show the narrowing really well. Like if there's narrowing in the blood vessel, if a patient needs a stent, but does not show the plaque characterization as well as a CT. But it shows the narrowing better than the CT. So everything's got its purpose, and there's not a ton of duplication.
Is there a relationship between cardiac arrest and heart attacks?
I think it's the same, essentially the same thing. Cardiac arrest, the heart stops. Heart attack, the heart stops. It's the major event. It's the probable occlusion of something, really a big vessel, or, that affects the whole heart. And then often, then it leads to an arrhythmia. Then it leads to ventricular tachycardia, ventricular fibrillation, and then people can't stand up. Like if your left ventricle's doing this, you can't perfuse your brain and you collapse. We don't want to end on that note. All right, we already got okay, so the goal is to play pickleball at 100 and well. Maybe tennis, maybe basketball. Yeah, all right, that's all my little ways to find me. Any other questions? Thank you so much for your time and attention and really good questions.